Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways. Stay informed with up-to-date clinical information and discover strategies to improve practice flow and efficiency. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.
Hi, and welcome to the Skin Sync podcast. Today we'll be discussing atopic dermatitis. Bucci, thanks so much for being here with me today. We're going to talk about AD and eczema, one of my absolute favorite things to treat in office because we now have so many fabulous therapies for our patients, no matter what age they are when they finally come to see us.
We're diving into a topic that really impacts millions of patients across the globe. We're really in this golden era of treatment. We've got tons of therapies on the market. We've got tons to come. So I'm really excited to kind of take a deep dive into this today.
So Bucci, let's go through a little bit of history and kind of the overview, first of all, of what we're treating in atopic dermatitis.
Right. So I think for a long time, people looked at atopic derm as just really a skin condition, right? It's just an itchy rash, a little eczema. What we've learned it is way beyond that. This is a systemic inflammatory condition. It's not just a skin problem. We've learned, that we have this atopic triad, right? Patients who have this condition are at higher risk of having allergies, but both environmental and food. They're at higher risk of asthma. So we know it impacts far more than the skin, and it can be a pretty devastating disorder to have. Typically, what we're going to see when patients present with this is just chronic inflammation in their skin. Itching is really one of the hallmark symptoms of this disease. And typically, you're going to also see kind of dry, scaly, inflamed skin. Presentations can be highly variable. So we'll get into a little bit of that later. But just want you to really understand that it's not just a skin disease. It really is something that is systemic.
For sure. And as we learn more about the type 2 inflammation, I think it really kind of opens our eyes to understand why there's barrier dysfunction, why we have this atopic triad, why patients also suffer with asthma and allergies and have other comorbidities with this disease. So truly, this is a type 2 inflammatory condition, and we need to keep that in mind when we're talking about therapies because we want our therapeutic options to go after that type 2 inflammation.
Absolutely. We just came off of a lovely conference, the Elevate-Derm Rapids Conference down in Puerto Rico. And one of our fellow PAs, Douglas Dirigero, gave a few excellent lectures, really kind of digging into the immunodermatology about this disease. I think we've all been, really enlightened about what we're treating. I feel like when I started practicing about 15 years ago, it was really understanding what the disease is and how to treat it. It was really as simple as that. But now with these new therapies, just like you mentioned, we've got to really go beyond that and understand what's happening, a little bit deeper.
For sure. And I think it was so kind of enlightening and empowering when Douglas kind of like christened us all as immunodermatologists.
I don't know if I'm qualified quite yet, but you know what? I'll take it.
I know. Well, we all had that moment and we all thought like, wait a minute, is this imposter syndrome?
Yes.
Like, can we treat immunology? Like, are we like ready to tackle this? But I think understanding, or at least even scratching the surface of the fundamentals of immunology and dermatology is so important because we need to be able to explain why we're using certain therapies to our patients and how these therapies are very different from what they've tried in the past. How often do you hear like, oh, I've tried a cream. Like I've tried that white cream in the tube, that white cream that comes with the letters on it, So patients get so frustrated because they feel like they've tried it all. And when we kind of do a deeper dive into immunology and help them understand that we're treating things in a different way, I think it really kind of opens their eyes a little bit.
Absolutely. So I wanted to let's dive into some of the current therapies that we have. We've had, topical medications, orals that have been on the market for years. We've got newly approved agents. So let's kind of dive in. So really, I want to kind of start with the foundation. I'm sure you do this in clinic. I certainly do with every atopic patient I have, is the foundation, which is skincare. We can give you all the best drugs in the world, but if your foundation is not solid, you may not have the success that you're looking for. So let's get into that. We definitely want to recommend for our patients that they try to maintain a healthy skin barrier. Good skincare, moisturizing products, fragrance-free agents. What are some of your recommendations for your patients when it comes to this?
So I'll always make sure that they have some good fragrance-free, sensitive skin type cleansers and emollient moisturizers. And, I'm not always married to a specific brand. Sometimes I'll recommend one brand if I have samples of it. Sometimes if a patient is highly allergic and has a lot of preservative sensitivities, I'll really go toward one that's very, very sensitive skin friendly. But you want to make sure that you have options with names that patients can recognize, or at least coupons that you can kind of circle the pictures of the exact brand that you want them to get.
Absolutely.
Because truly they get so overwhelmed when they walk into the grocery store aisle and there's 1,000 different moisturizers in front of them. And they will sometimes pick the pretty packaging, they sometimes will go for like what looks nice, but that might not be the nicest thing for their skin.
Absolutely. And really, in addition to the skincare products, really telling patients how to bathe. Oftentimes it sounds silly, but making sure that they're taking relatively short showers, that the water temperature is more lukewarm than hot, patting dry, applying emollients immediately after. Those little things, a lot of people do not do it. They really use their shower time as relaxation for 30 minutes, or they'll strip their skin completely dry of all of its oils. And so I think it's important to tell them just some of the basics. How do you do things? And I like to provide handouts for this as well.
For sure. And sometimes just not only do we need to provide them with the do's, but also the don'ts.
Yes.
Don't scrub, they don't need to physically exfoliate. They don't need to take a loofah and get rid of every single scale on their skin.
Exactly.
That can sometimes be detrimental. Sometimes like medicated salicylic acids and or benzoyl peroxides and or other things might be actually detrimental toward atopic skin barrier. So we want to make sure that we're just giving them, good recommendations for bathing, for cleansing, for moisturization. Completely agree with you there.
So then moving right along to topical corticosteroids. This has been our mainstay of practice for really many years up until, I would say, the recent maybe decade or so.
Sure.
These agents were really game changers in treating inflammatory skin disorders, as a whole. Now, what we've learned, of course, over the years that with inappropriate use, they oftentimes can cause some pretty serious adverse reactions. And in addition to that, they're really not good long-term therapies. So what's your take on topical corticosteroids? Do you still utilize them in practice? How often nowadays?
So even though I've been in practice for 20 plus years and consider myself a very old school dermatology provider, I think that these are truly old school therapies.
Yeah.
I use these as a step edit. I use these as a step through. I tell patients, these are not going to be your everyday therapy. They are not going to be your best friend. They are there for rescue only. And if patients have asthma or they have family members with asthma because they have atopy, they kind of understand that. They understand the concept of rescue. But then you tell them that this is not going to be beneficial for them long-term. There are so many new therapies that are what I call beyond steroidals because I feel like they do more than steroids can. But I do use old school topical corticosteroids and TCIs as your step through must-dos before we move on to the therapies that I truly believe can provide them with some better overall skin barrier repair and overall reduction in their inflammation.
Yeah. And I think really these days, we really don't have an option when we're dealing with insurance providers. We really have to kind of go through these step throughs, as you say. Now, there's still value in some of these agents, and some patients are, hardcore. They want to hold on to what they've used for many years. But I think it's important to recognize that we have so many better options on the market now. Moving on to some of the, I guess, one older, one newer agent, the PDE4 inhibitors. So we initially had crisaborole. It was a kind of, new to the market topical agent for atopic derm. I think a lot of us, there was a very small set of patients where we can use that medication. Number one, there was a lot of stinging and irritation that came with it. So you had to be very cautious and really counsel patients about that. And second, it wasn't really the most effective product. I think it still has value. It's a non-steroid, but definitely something that I think has kind of fallen out of favor with the new agents that are available.
It does have a very low age indication, which I love.
Right.
So
Yes, this is true.
love recommending therapies that are FDA approved for the age of the child that I'm treating. So I do love the fact that it has that 3-month and older age indication. You're just going to have to really counsel mom or dad or caregiver about the stinging and burning for those little tiny pumpkins that can't verbalize. They're just going to scream. So you need to make sure that you're not applying that to a broken skin barrier.
Right. And I think there's value too. We do have, I have two little ones myself. I think for a lot of parents, they're not ready to jump into systemic agents. They're not ready to make that big decision. So we still have to utilize some of these agents. And I think, just like you mentioned, this is a great one for patients who are much younger. So we do now have a newer topical PDE4 inhibitor, roflumilast cream. It is now currently approved down to ages 6 and up for atopic dermatitis. And, what are your thoughts about that medication? Have you found some utility in that in your clinic?
I sure have. So I really love roflumilast for those AD seb derm crossover patients. Roflumilast comes obviously in 3 formulations, a foam, a 0.3 cream, and a 0.15 cream. So it can be a little bit confusing. So when you are directing your MAs exactly what to put into the medical record, make sure you are being very specific on saying, I want the roflumilast 0.15% cream for atopic dermatitis when we're treating AD. So six and up age indication. So for our slightly older kiddos, it is a once a day therapy. It was originally FDA approved for mild to moderate. They had 4-week data, which was pretty good and pretty nice. Very nice data for sensitive skin areas and very, very low incidence of stinging and burning, especially for those very sensitive eyelids, face, neck folds, axilla, genitalia. So if you're looking at a kiddo that looks like a sebderm AD crossover that has a lot of cradle cap or had cradle cap when they were a baby, and they definitely have that atopic look, and you can also see sebderm developing within them or already as a comorbidity, I think that this is a great option.
I think for patients who are skin of color, who deal with a lot of the post-inflammatory hyper and hypopigmentation, this medication actually has some data showing that it can help improve that. So I think that's another really good benefit to this topical agent.
Fantastic point. Absolutely. So our patients are so bothered by those dyschromias, whether it's hypo or hyperpigmentation. And when they have data to support the fact that we can promote that in clinic, that's really, really fantastic.
So kind of moving on to one of our other new agents on the market, or newer agents. And this is a first-in-class topical medication. It's topical tapinarof cream. This is an aryl hydrocarbon receptor agonist. It's currently approved for atopic derm and psoriasis. What's the indication for atopic derm? Is it down to 3 years old? 2 years old. That's really impressive.
Very, very impressive. So not only is it impressive that they got a low age indication, in their clinical trials, they actually did specific recruitment of the younger age demographic. So 20% of the patients included in the clinical trial were between 2 and 5.
That's excellent.
20% were between 6 and 10. And I might be getting those ages wrong, but like the older kiddos, 20% were the slightly, younger teens, 20% were the slightly older teens, and then 20% were adults. So 80% of the patients in this clinical trial were kids. So for those of us who treat peds and treat a high percentage of pediatrics, that was incredibly impactful. They also specifically recruited more than 50% of their patients were skin of color. So they did a very deep dive into looking at how the dyschromias did improve and the hyperpigmentation, hypopigmentation improved with just a once a day therapy. They also got the indication for moderate to severe atopic dermatitis. So they took potential biologic patients and said, here's a cream, use it once a day. Let's see how you do. And more than 50% of patients got to clear, almost clear. So
that's a pretty bold move for a company during a clinical trial. So I'm highly impressed. And I think clinically it's been a very exciting drug to have. Easy to prescribe. The coverage is usually reasonable. And if not, at the very least, they have great rebate programs. So just something that I've been really happy to use in my clinic. One more topical agent I want to mention, and that is topical ruxolitinib cream. I'm currently approved for both atopic dermatitis and vitiligo. And this medication has been really helpful to have in clinic. Number one, because we can use it almost anywhere on the skin. We do have to limit it to a 20% body surface area, but it can be used in very sensitive areas where you would not want to use a steroid, eyelids and intertriginous regions. So that's been one major benefit with it. It does have pretty good efficacy, especially comparing it to topical steroids. There's a little bit of a hiccup sometimes in getting it approved. You do have to go through a couple step edits based on your insurance plan, but that's been an exciting agent to have on the market. There is one small thing to mention with this topical medication. Why don't you share that with us, Shanna?
So I do love ruxolitinib, and we call it Rux cream. So ruxolitinib is a BID dosing. And as you said, it's 20% body surface area, 12 years of age and older for our patients with atopic dermatitis. But we have to explain the dreaded black box warning. So that is like truly the only con with this medication. It's the only kind of sometimes things that might slow us down in our everyday clinic. One amazing pro about this medication is they have minute itch reduction data. So if your patients are incredibly itchy, being able to say, hey, like you can put this sample on and potentially feel better. Actually, some patients had statistical significantly better improvement in their itch reduction in just 15 minutes.
That's impressive.
So it's nice. And so sometimes they don't care what is written on the label if they feel better and if that itch gets better. But we do have to explain the JAK inhibitor, standard black box warning, which is coming now on every single JAK inhibitor. Interestingly, this same black box warning is not on the oral version of ruxolitinib that was released years and years ago. But unfortunately, it got lumped into the FDA kind of black box warning for all JAK inhibitors moving forward. So I'm hoping that the FDA will someday relinquish that. Who knows? Because pimecrolimus and tacrolimus still have an FDA black box warning on them, and they've been out over 20 plus years.
Exactly.
But we do have to explain JAK inhibitors because there was a JAK inhibitor that was given to very sick patients, 50 years of age and older, with cardiovascular risk factors, and they were already immunocompromised. And they were put on JAK inhibitors for rheumatoid arthritis, so for a completely different disease state. And some bad things happened. There was a higher rate of all-cause mortality. There was an increased rate of major adverse cardiovascular events. So when a mom sees that we're putting a topical cream on their, kiddo twice a day, and they're going to be worried, like, this is going to this could cause heart attacks and strokes.
Right.
You need to take a moment and explain that black box warning, that it was given for an oral version of the JAK inhibitors for a completely different disease state, but it is on the label. So we do need to take the time to discuss it.
And I think with that discussion, if you paint that picture accurately, but still well, patients really are pretty receptive to it. I think it was the same thing with the black box on the TCIs. I think patients are really open. They trust you. They're there to get your, best advice. And so if you paint the appropriate picture, give them a good sense of what the real risks are, I think they're more than willing to try these therapies. A lot of them are approved down to, 2 years of age and 6 years of age.
That's okay.
That's a huge reassurance for patients, especially as, parents, mothers and fathers. I know that if I'm thinking of a medication, prescribing it for my child, I certainly want to know, like, has this been tried? Has this been tested? Is it FDA approved? I think that gives me some peace of mind to know that this is something I can safely use in my kid.
I think that those are fantastic options. And I would absolutely dive into those non-steroidal or beyond steroidal options. It's not the same thing that you've tried before. Like, this is totally different. This is, by the way, safe to use every single day. And you can actually get some repair of that skin barrier. We can actually make things better.
Thank you, Shannon. I love doing this with you. And everyone listening, I hope you guys found today's content helpful.
I'm hopefully going to open up some hearts and minds to the options of using some of these new medications for atopic dermatitis. Stay tuned for future episodes about systemic therapies and the game-changing biologics that we have now available for our atopic dermatitis patients. I'm signing off for now. Take care.
Thanks for tuning in to SkinSync. Don't forget to subscribe on iTunes or Spotify so you never miss an episode. We'd love to hear from you. Send your topic ideas to admin@elevate-derm.com. If your suggestion is featured in a future episode, you'll receive complimentary registration to one of our upcoming conferences. To explore more of Elevate's educational and career resources, visit elevate-derm.com.